Hi, good day, folks, again, and welcome to this brief discussion on mental capacity and compulsion, which is designed to complement the existing lecture that you have had previously. So, just a brief definition of what mental capacity is. Mental capacity means being able to make one's own decisions, and the consequence of any discussion of mental capacity is legal, of course. What is the legal consequence of not seeking consent for a patient? And we discussed that in a previous lecture with respect to the legal consequences of being charged with assault and or battery. Um, so the issue with mental capacity, again, apart from the legal consequences, is two questions really. First question is when an adult is incapable of deciding whether to proceed with treatment, how can you as a medical professional lawfully instigate treatment without being um, finding yourself on the wrong end of the law with respect to the aforementioned assault and battery, right? And the second question is, if an adult at any point refuses treatment, can that refusal be overruled by you, the medical physician, on the premise that the patient is acting irrationally? Okay, very important two questions. So what? So what if the patient has no mental capacity, right? So if the patient has mental capacity and you go ahead and instigate treatment that the patient does not wish, of course he could be charged with assault and battery. Its refusal of consent is a patient's right under their exercising their full autonomy to refuse consent. You're violating the patient's human rights. There may be a possibility of restraint and or detention if you, depending on what kind of treatment you decide to instigate. Um, there's the issue of protection of vulnerable populations like patients with mental disorders and minors. And then there's also the issue of research that patients with mental capacity are they capable of, of, of entering research projects and so on. So how do we assess mental capacity? So we have a choice. We can either use a test of status, which assesses intelligence and determines that all who are above a certain score are designed to have mental capacity. But you could see immediate problems with that. Not everybody who has you could be as intelligent as you could be as intelligent as the highest professor, um, or you could be have little or no formal education, but still have the mental capacity to make certain decisions about your health, right? So just because you don't have an IQ of 190 doesn't mean that you don't have capacity. So you just dispense with a test of status when it comes to assessing mental capacity. So we can use a test of outcome. So it judges capacity by the rationality or perceived wisdom of the decision. But just as we'll see later on, just because somebody makes a decision that is considered unwise, from a medical point of view, doesn't mean that they don't have full mental capacity to make that decision, right? So we have dispensed with the test of outcome. So the one that we do use is a test of function, and it assesses any person's understanding of a particular enterprise, right? So it's not based on intelligence and it's not based of the perceived wisdom of the decision. It's based on the patient's understanding of what needs to be done. So when you're having to assess patient capacity, all you need to do is ask the patient four questions, right? First question, does the patient have a general understanding of what decision they need to make and why they need to make it? Second question, does the person have a general understanding of the likely consequences of making or not making that decision? Third question, is a person able to understand, retain, use, and weigh up the information relevant to this decision? And lastly, can the person communicate the decision, for example, by talking, using sign language, or by any other means, right? And if you have patients who don't speak English, don't just assume that they don't have capacity because they can't communicate that decision for you, right, with you, right? The onus is on you to find some kind of interpreter service so they can communicate, right? So just four basic questions. That's all you need to assess a patient's mental capacity. We discussed this case in lecture, so I don't want to delve into it too much. Um, so the law relating to decision making on behalf of people who lack mental capacity is to be found in the Mental Capacity Act 2005 in the UK and its accompanying code of practice. So I would urge you to have a brief look at the Act. Um, And in summary, the Act directs that what must be assessed is a patient's capacity to understand what is at stake and to act on that information. And any inability to make a decision must relate to a disturbance or impairment of the functioning of the mind or brain, which may be temporary or permanent. And the Act further states that everyone must be presumed to have capacity until proven otherwise. All practical steps must be taken to help someone make a decision. And very important, just because someone makes an unwise or irrational decision does not mean that they lack capacity. So just because the patient doesn't agree with what you're doing, what you're saying, or what you're planning, it doesn't mean that they're um, non-compos mentis. And the Act further states that a lack of capacity cannot be established merely by reference to a patient's age or appearance, so men don't make assumptions about the patient's education level. Or it can't be established merely by reference to a condition or aspect of his or her behavior which might lead others to make unjustified assumptions about capacity. And we went through this case in the lecture as well, so I won't go into too much detail about it. So who are the patients who lack capacity, the specific subgroups, right? Patients who are unconscious, alcohol overdose, drug overdose, etc., right? They lack capacity, they can't make decisions, they can't understand what's at stake, right? Children, different countries have different legal definitions of who is a minor. In Trinidad, once you're under 18, you're considered a minor, right? So once you're a minor, you're considered to lack capacity because they don't have the understanding. Patients with unstable psychiatric illnesses, I put unstable specifically because patients who have stable psychiatric illnesses, and it goes back to making assumptions about the patient, right? So especially in Trinidad, with a certain amount of taboo surrounding mental illness. For example, once somebody's diagnosed as having schizophrenia or mania or depression, they automatically assume not to have mental capacity because on the basis of their psychiatric illness, right? But patients who have well-controlled, stable psychiatric illnesses like schizophrenia, like mania, like depression, oftentimes do have the ability, the mental capacity to understand what's at stake, right? So I've deliberately put patients who lack capacity are those who have unstable psychiatric illnesses. Patients who have dementia, Alzheimer's, patients who are under the influence of drugs, I mentioned alcohol, we also have opioids, in Trinidad they have Zesa, and then patients who are in a metabolic coma for any reason, renal failure, hepatic failure, right? This metabolic coma leads to unconsciousness. So these are the specific subgroups of patients who lack capacity. And when you're treating patients who lack capacity, two questions must be answered. On what basis is the proposed treatment lawful? And who authorizes such treatment? And you can use two principal tests. You can either use the best interest test or the substituted judgment test. So the best interest test requires that decision makers like you, the professionals, consider what the overall welfare of the patient demands. And in theory, it is an objective test. So this is really usually applied in Europe and the UK. So we consider what is in the patient's best interest. What if the patient comes in and they're unconscious and you think they need an appendectomy, you think that the overall welfare of the patient will be better served by taking out this appendix, and you as a medical professional make that decision to go ahead and schedule an appendectomy without the patient's consent, right? Substitute judgment is more used in North America, and it demands an attempt to discern what the patient would want, he or she were able to decide for himself or herself, right? Used in US and Canada. And we discussed the case of poor Karen Quinlan and why her parents sought to disconnect her from the ventilator, and why she remained on the ventilator for as long as she did. So the problem with substitute judgment, some patients never have capacity. Some patients don't have family, so you don't know what the family. So the family members are usually go-to people to kind of decide what the patient would have wanted. Some patients don't have family. Sometimes you have difficulties with identifying family members. So you have difficulties with identifying next of kin. And oftentimes the family members may not be in agreement as to what the patients would have wanted, right? So for our purposes, we use the best interest test, right? So before doing whatever the doctor considers to be in the patient's best interest, you as a medical physician must take reasonable steps to establish whether the patient lacks capacity. Um, so you must reasonably believe that the patient lacks capacity in relation to the matter. So do they belong to one of those subgroups we previously discussed? And you reasonably believe that it will be in his or her best interest for the act to be done. So is it surgery? Is it a medical procedure, right? And if you employ that best interest test, you don't incur any liability when you do what you think is in the patient's best interest, right? So you can't be sued, for example, for assault and battery subsequently. When you're making the determination, it must not be merely based on patient's age or appearance, or a condition of his own aspect of his or her behavior, which might lead others to make unjustified assumptions about what might be in his or her best interests. You must also consider whether it is likely the patient will at some point have capacity in relation to the matter in question, and if it appears likely that he or she will have capacity at some point in time, when is that likely to be? But usually in emergency situations, it is unlikely the patient will regain capacity in any short period of time. And the physician must, so far as reasonably practical, permit and encourage the person to participate or to improve his ability to participate as fully as possible in any act done for him and any decision affecting him. So don't just rush and say the patient has no mental capacity and try to really engage with the patient to find out if they do or don't have mental capacity, right? And where the determination relates to life-sustaining treatment, the medical professional, in considering whether the treatment is in the best interest of the patient concerned, must not be motivated by a desire to bring about his or her death. In terms of still continuing with best interest, physicians should consider, as far as reasonably practical, the person's past and present wishes and feelings and any relevant written statement made by him when he or she had capacity, the beliefs and values that would be likely to influence his decision if he had capacity, and the other factors that he would likely to consider if he were able to do so. But you should consider all of these, but remember that your overarching principle is that you must do what you think is in the best interest of the patient. By all means, consider these factors, but again, your overarching principle is to do what is in the best interest of the patient. You should also consider, if practicable, to consider the views of anyone named by the person as someone to be consulted on the matter in question, anyone engaged in caring for the person or interested in his or her welfare, any donee, any lasting power of attorney granted by the person, or any deputy appointed for the person by the court. So briefly, we'll talk about advance directives. Advance directives are not legally binding in Trinidad. However, powers of attorney do have legal force. And even in the US, UK, Europe, and Canada, only advance refusals of treatment are legally binding, right? Advance refusals of treatment must be done in writing and witnessed, and all other advance refusals need not be in writing, okay? So the problems with advance directives, some must be in writing, we saw before, and some don't have to be. So it can create some confusion. If it's not in writing, then evidence of previous capacity will be difficult to establish. The treatment addressed in the directive must be very, very specific, or it is considered invalid. And of course, there's the effect of changing circumstances. So how do you know that that decision that the patient made 20, 30 years ago will still be valid now? They may have refused treatment, and they may have had, and in subsequent to that 20 or 30 years later, there may be a medical treatment that is now applicable to them and can prolong their life or save their life, okay? Right, so this brings us to the end of the discussion on mental capacity, and I'll see you for a subsequent discussion in another lecture, okay? Thanks for your attention as always.